of all, I'd just like to welcome everybody. My name's Glen Howard. I'm the Head of Analytics and Evaluation for Health Innovation East Midlands. So what we're going to cover today is, obviously after the introduction, we're going to talk about identifying benefits. And there's going to be a few minutes to talk about your challenges. And then we're going to talk about measuring benefits and impact, some ideas around that. And again, a few minutes to talk about your challenges. And then we'll conclude with how we can take this forward. So just a bit of housekeeping. Please turn microphones off if you're not speaking. We are going to be using Teams polls throughout, so it'd be really good to get your feedback. But feel free to ask questions and use the chat. Might not be able to address all of them, of course, but we will do our best. But there will be time to discuss your experiences and challenges. Just let everybody know the session is being recorded. We will stop the recording when people are asking questions and start again when we go through the slides. So first of all, for those that aren't aware of the Health Innovation Network, huge impact across the country, really about improving patient care. That's really what we're about, but obviously using innovation to do so. If you're not aware of your local Health Innovation Network, please seek them out, get in touch with them, see how they can help. And the kind of things that the innovation networks do, it's about finding those innovations, about testing those innovations, and it's about implementing those, supporting the implementation of innovations. So we can look at those slides in more details afterwards. But just to give us a sense, Shanita kindly put our poll up, first poll up. Just get a sense of where people are coming from. NHS Trust, local authority, ICB, public health, regional bodies, including HINS, charity voluntary sector, company, innovator, and other. I'm not going to try and find out what the other is, because I would just get too engrossed in looking at that. So let's just have a look at the polls. I can just see it there. Good chunk from about a fifth from trusts, 10th from local authority, fantastic. ICBs as well, regional, etc. Great. We've got colleagues from charity voluntary sector as well as some innovators. That's fantastic. Brilliant. Thank you very much. That's great to know where everyone's come from, and you're all incredibly welcome. So next is brilliant. Thanks, Nicola, for clarifying. What's your role in relation to benefits from innovation? Really intrigued to find out what people's roles are. Is it that you've got a strategic responsibility for the program? Is it that responsible for delivering benefits? I think Shanice is going to put this poll up in a moment. Are you responsible for identifying and delivering benefits? Are innovations given to you? You want to get more out of them? Is it that you want to get a better understanding of how you can identify and or measure benefits? Or maybe you're in the, what are these benefit things anyway? Here to find out really what this benefit stuff is all about. And some people, it might just be personal development, future roles for your project, something that's of interest. I'm slightly biased because I find benefits absolutely fascinating, which is why I've been involved with benefits for more years than I care to acknowledge, and we're talking decades rather than years now. So I find them absolutely fascinating. But the most people want to get a better understanding at the moment. Some people have a strategic responsibility, a good proportion for program delivery. That would be really helpful to the session. Hopefully, helpful to give an idea of how those can be identified and measured. And yeah, a good chunk of people just want to get in a better understanding. Well, hopefully, the session will work for all of you, because that's exactly what it's designed for. And the next poll that we'll put up is really, what's your experience, just to get a sense of what people's experience is in relation to identifying and measuring benefits. Is it something that you do a lot? You like to get some new ideas. You do it, but you're not sure you're doing it the best way. I'm sure you are, but maybe some ideas. Not very experienced, something that you've had to do, but you're maybe not so confident. Not really done much, but you know that you need to. Or is it a whole new area, whole exciting new area that you're beginning to explore? So just wait a few moments for those. Great that people are great. There's some experience. That's fantastic. It'd be great to get thoughts on some of the things that we're talking about. Probably about half people do it. That's great. People are involved in benefits. Not sure you're doing it the best way. I'm sure you probably are, but maybe we'll come up with some things that can complement what you do. That's fantastic. Thank you very much indeed for that. That's really helpful to get a sense of who's with us today, and everyone's incredibly welcome, and I hope you find the session useful. The first stage in managing benefits is to identify them. The trick, as with lots of things, diagnoses, understanding really helps helps any subsequent work within that. So this session is inspired by a couple of works. Sorry, Julie.
I think the slides have stopped sharing, Glenn. I can't see them on my screen anymore.
Thank you for that. As they come back.
Yeah, got them now.
Brilliant. Thank you. I have no idea how I managed to do that, but there you go. Apologies. Thank you, Julie. Really appreciated. How to identify benefits, and this is inspired from a couple of pieces of work around that the Innovation Collaborative did a few years ago. Fantastic resources, which I'll show a link to later. And those that have been around for some time, unfortunately as I have, will recognise Cranfield's approach that really pioneered some of this a couple of decades ago now, but still really useful work. What is a benefit? It's a measurable improvement, but what's key is it results from a change. Benefits don't appear. You need to do something to enable them to happen. Considered advantageous by at least one stakeholder. Useful statement because it makes you realise that other stakeholders might not find them advantageous, and that needs to be understood. Contributes to an organisational objective. It's really key that we understand how our benefits, how the work that we're doing meets those organisational objectives. The value, and it's about the value perceived or realised by those experiencing the outcomes of change. And that's really the key to measuring and understanding benefits, is looking at the experience and what difference does it make to people that experience the change. So we improve a service, we might improve something that means, let's say, a patient no longer needs to go to an outpatient appointment. That could be a fantastic benefit for the patient, that may also have benefits for the health and care system as well. Benefits are usually delivered within a framework, as most things are. Numbers out there, but basically they go with the standard process. You identify the benefits, you plan how you're going to deliver those benefits, deliver them, measure them, did you deliver them, and then look for more. This virtuous circle of continually looking for benefits from a system. So you can never you never necessarily need to stop looking for benefits throughout the life of any innovation, any project. When it goes to business as usual, you can continue to look for benefits. NHS Digital's 5-stage approach, and again the link's on there, very similar about identify and quantify. They've got a way of a step of value and appraising those benefits, and then plan, realise and review. Benefits is an area where it's quite useful to be a little bit more precise, because benefits, benefits and change, the way that we use the terms sort of in everyday work, useful to be a little bit more precise and think about outputs as the products, outcomes the result or the difference, and benefits is the measurable improvement resulting from an outcome. So again, it can be useful to think of those three different concepts. I'm less bothered about the names, but recognizing there are three different concepts is really quite helpful and starts us to think about, when we're identifying benefits, what we need to understand. And for me, I think there's two main models, and I'm sort of been doing this a while and familiar with the benefits dependency network on the left, which I particularly like because it understands the change, what the change is, and the benefits, the enabling changes, what you need to put in place to make that change happen, links to strategic objectives. So that works for me. But a lot of people use logic models that work in a very, very similar way, and people are familiar with those. It's all about understanding how the change in the pathway links to the benefits. And if you don't understand the change in the pathway, it's going to be really hard to be able to identify and articulate those benefits in a meaningful way. So it's always understanding the process, the way that the health and care process changes, the way the pathway changes for patients. It's about understanding the relationship between change and a benefit. It's rare to get a benefit without a change. It's more common, unfortunately, to have a change which doesn't deliver the benefits that people were hoping, or potentially delivers disbenefits, which we'll mention in a moment. So for me, it's really about understanding three things: the change required to deliver the benefits that are needed, and how that links to strategic objectives. So how can we relate this back to what the priorities are for that organisation? So it's really important that we understand those three aspects. And what is the evidence? What is the evidence that the change will deliver those benefits? What is the evidence that those benefits are required? So it's always about the evidence that you have, that the change will deliver the benefits, and the innovation will deliver that change. There are a number of different types of benefits people talk about. The main two, or main three, and in fact I'll come on to quality benefits in a moment. The main two are about cash releasing and non-cash releasing, and people often get confused, understandably, between the two. Cash releasing benefits reduce the cost to health and social care bodies in a way that resources can be reallocated elsewhere. You can spend it on something else, for example, funding the innovation. So it might be reduce headcount, reduce travel costs, reduce the amount of printing, for example. Non-cash releasing benefits, they provide economic value through savings, through increased efficiency and effectiveness, improved input to output ratios, etc. But they don't release money to budgets. So, for example, ambulance conveyances or GP face-to-face appointments or outpatient attendances, they have a value, an economic value that can be ascribed to those, but reducing an A&E attendance will not necessarily release that the cost of that into somebody's budget, unless it's significant enough to become cash releasing. And the other two benefits that people are aware of, or categories of benefits, are quality benefits, which are those that can be quantified but cannot be monetized. They should always be quantified wherever possible, and they're really important to measure those quality benefits. And the final section is societal benefits. They provide monetized economic value, but are realized outside the health and care system. For example, quality adjusted life years. So it's a way of measuring the value, and to be able to, particularly useful to compare between innovations or changes. Any talk of benefits really must talk about disbenefits. People don't like the word, and some people try and obfuscate or obscure the disbenefits, but I think it's as equally as important to manage disbenefits in the same way as you manage benefits. So, for example, it's really easy to reduce length of stay in a hospital if you're less bothered about things such as mortality, readmission rates, and quality of care, etc. So measuring those disbenefits, you can measure disbenefits and you manage them in exactly the same way as you measure benefits. And often what you might want to do is be assured that you are not introducing those disbenefits. So cash releasing, non-cash releasing society can be what's called monetized, and that's a process of expressing as a calculated financial value. Often people misunderstand that means it's a saving, and that's cash releasing, particularly. But it's a way of articulating the value in in terms of pound notes. But only cash releasing benefits release in a way that resources can be completely reallocated elsewhere, and can be claimed from the budget. And that's one of the challenges people have in understanding what may be cash releasing and what's non-cash releasing. They all add value, but the value is articulated differently. And difficult to sensibly monetize. There's things you can do, but sensibly to monetize quality benefits, but they can be quantified and measured, and I would argue they must be, because they're essential to capture and measure and track. It's much of the value of the work that we do in healthcare. It's people recognize that there is financial challenges and we need to be efficient and effective, of course, but actually what motivates people is delivering a high quality care. Measuring that within any project, I think, is as important. Personally, I think it's as important as measuring financial benefits and those monetized benefits. It's key for stakeholders, key for engagement. Benefits usually come from doing something new, doing something different, or stopping doing something. If you're doing something new, then it raises questions. Where's the time coming from? How are people going to know when to do this for which patients, and how to do this? So doing something new, there's always those aspects of training, that implementation. If it fits in a pathway, where does it fit into that patient pathway? How are people going to know that this is what they need to do? If you're stopping doing something, that's great. That can be great, but that also needs to be managed. If you're stopping it, people need to know that to stop doing it. And often, if you're doing it previously, there's perhaps some need. So it might be that you're doing something different. It might be that we can actually no longer have to do something, but we really need to understand that. And if we're doing something different, again, we need to understand the time implications of that. Does it take longer? Does it take less? How are people going to know? How are people going to realise that this is the situation where we need to do this different thing? So benefits usually come from one of those 2-3 categories. A really useful way of thinking about any change and thinking, does the change enable us to do something new, something different? Will it enable us to stop doing something? And the benefits will be different for each one of those. And it's really helpful to consider any change is likely to deliver benefits to one or more particular perspectives, and actually articulating them separately. So this change means X for patients, it means Y for staff, it means something different for healthcare organisations and for the system itself. So it'd be useful to articulate the benefits, the change, and how those are felt for those individual key perspectives. I think it's really helpful to understand that, because what's important to the system might be different to the patient, and the same change might deliver benefits for one or more. Once we've identified the benefits, we can then measure them. And the secret to measurement is the identification, and particularly thinking around the better we identify a benefit and understand what the real benefit and the real change is, the easier it is to really understand how we can measure. A lot of people are familiar with the quality improvement approach of considering the outcome process and the balancing measure. People are quite familiar with that, and if not, I recommend thinking about it, because it's a really useful way of looking at the change. Do we understand the outcome? Do we understand the process? Do we understand the balancing? And recognising there are 3 separate things that we'll be measuring. But if you convert that to a benefits framework, which I think is useful, it's not a perfect fit. Concepts are, and we talk about the outcome and the benefits, but outcome will lead to benefits broadly. The process is similar to the change. So if we're measuring the process, if we're measuring the change, can we understand if we've got good evidence of how that relates to the benefits? So can that be a proxy measure? We might measure on a small number of patients and that are typical, and then say, well, this is what it was for those. We can then roll it out based on the process measure. Sometimes that works. And disbenefits are the balancing measures. So how can we, and again, we really need to look at those disbenefits, and Gordon gave a really good example of some disbenefits that you could really try and understand and measure what those impacts would be. I usually start off with a change. If people are already busy, if we give them something else to do, they're going to have to stop doing something else. So how do we enable them to stop doing that other thing? That's a useful thinking, I think a useful way of thinking. But what you're trying to understand is how much change happened. So it all comes from the change. How much benefit resulted from that change. The extent of any disbenefits encountered. And again, sorry to dwell on that, Gordon, you gave a really good example of where the disbenefits could really cause a problem. If you ignore the disbenefits, I think you do so at your peril. Understand them, measure them, quantify them. We recognise there may be a disbenefit with this. We will measure them, we will understand them, we will manage them to make sure that they are contained. So first of all, did the change happen? Was there a benefit? And then, was this due to the new intervention, this concept of attribution? Did we cause it? Did it happen? Then did we cause it? And you sometimes separating them out as two sorts of ways of thinking can be quite helpful. What do I measure? How does this work? Okay, have we measured the benefit? Then can we measure the benefit? Can we see if it's happened? Then did we cause it? Thinking it separately can be quite helpful. Classic ways of driving attribution is a standard before and after. You take a suitable baseline, you compare the measure before and after the intervention has been introduced. And again, I'm going to mention here, making single points, it's 22 this year, it's 24 next year. Drawing conclusions from 2 points is, shall we say, limited. This is where your statistical process control, your SPC, which I'll mention a little bit later, can be really useful because you can see that trend. Again, you're looking at that trend. So you're looking at the historical data based on that trend and extrapolate where it would be. So this is what sometimes people call the counterfactual. So I was speaking to someone recently, the hospital was really busy, had lots of admissions, but how many additional admissions would they had they not had the admission avoidance service in place? So what they could do is overlay the number of additional admissions they would have had that service not been in place. So I think it's quite counterintuitive to clinicians, because you're saying what would have happened, and actually this is what did happen. But what you're doing is you're trying to model that it would have been what it would have been had it not happened. So that kind of trend analysis can be quite useful. Obviously, you've got your control versus an intervention, and again, if the two are comparable, you can see if it's the only thing that has changed, was your innovation? Was it because one had an innovation, one didn't? So it needs to be suitable, and that sometimes can be quite difficult to do. Something can have a natural experiment in the sense that if you're rolling out at the early stages those areas that haven't been rolled out to, potentially that's one way of doing it. But the control this invention can be sometimes difficult because you might not be able to get a control group to be able to do that. And then there's a difference in difference, which is a combination of those techniques. But really, the things you're looking at, you can estimate the counterfactual, what would have happened had we not done. That can be really useful. I think it's useful to also consider, is this consistent with the theory of change? Does it make sense that this will have led to that? This is what we expected to happen. Has it happened? What unexpected things have emerged throughout the project? Are we still comfortable that actually there is logic behind, we've changed this and this is what's resulted from it? You want to be ruling out any alternative explanations. Could it have been due to something else? And actually test that and try and find out whether that is the case. And each model will have their strengths and weaknesses. It's difficult to get a perfect measure that demonstrates everything in one metric, and you might need to have a combination of different things to measure to be able to really understand the impact. But some considerations, I think these will be helpful, and this is based on our experience of supporting lots of projects to measure their impacts. I think first of all, be clear on the questions that you're asking. What is it you're trying to understand? Again, identifying the benefits, as we said earlier, will make that really, really helpful. But really be understand, what are the questions? What is it that you're trying to demonstrate? What is it that you want to understand? Without context, data is limited value. As Douglas Adams found out, 42 was a very interesting number. but without the context, it has limited value. So really, you've got to understand the data that you're using. Can you make a sensible comparison to gain confidence in the effect that you can cause? Is it possible to make that comparison? Sometimes it isn't, but often it is. So it's really asking those questions. As I mentioned before, avoid two-point comparison. That doesn't really help. Consider measuring over time, statistical process control. I'm going to speak to the making data count work. I'll send a link through that before. We work very closely with Samantha and the team. Done some fantastic work to help people understand measuring over time and how that's reported. But most of all, be proud of your benefits and share them. Share them with us, inspire others. This is what can be achieved. But also, and most importantly, share with those people that have made the change. Changes, I've been a change manager, I've been involved in change for a number of years. Change isn't always bad, but it's always an effort and it can often be challenging. But feed that back to the people. Most importantly, feedback to the people that have delivered those change, that the change is delivering an effect. We can often assume that people will see it, provide the evidence that it is. This be clear, particularly if it's outside of the particular area, hard for them to see and say, you do realise we've done this. This is the effect that we expect that would happen. We've helped people manage the cardiovascular disease. This is the reduction in heart attacks and strokes we expect in the future. The UHP size of the prize kind of work can help with that. So be proud of those and share them. Data is often a challenge. So some areas that would recommend considering looking for data. Data collectors are part of usual care. We do not like to ask for additional data collection and always look and try and get data that's collected as part of that usual care. But there are information governance consideration and challenges behind that to use that legally and safely. But really, we always look what's already collected first. How can we include patients and user experience in what we're looking at? That's really important. Because that's the reason we're doing it, and that's why we're making the change to improve the care of patients. But how do we know that it's an improvement? So, for example, someone might not go to an outpatient appointment, and that might be fantastic from that perspective. But if that leads them being unclear about their care or what comes next, then actually that experience might be not as good as we think it is. So it's really important we understand it. Can we exploit an existing data set? We've got lots of quality and performance metrics. Can we look at those in a slightly different way, cut them in a slightly different way to tell us that we're delivering a really good the changes delivering the benefits that we want? So, for example, we often collect 30-day mortality in hospitals, so that can be a really good balancing measure to ensure that has not been negatively impacted. Think about things from the whole pathway. Always think about things from a patient's perspective. The answer often is in one sense asking the patient, follow the patient, and join data across departments or organisations, and be aware that if we see something you might make a change in one part of the organisation and part of the healthcare system, what effects does it have elsewhere? And it's helpful to understand that. And again, the benefits identification processes and understanding the patient pathway will really help you with that. New data collection, keep to a minimum would be my recommendation. You really need to then consider the benefits and costs of collecting that additional, because if it takes time, we've really got to understand that it might take time, might take effort. We also need to think about the timing, because if you're using existing data, you might be able to get that retrospectively, but if you're collecting new data, you will need to capture your baseline beforehand. That creates some timing challenges. So again, new data collection, it might be required, but I suggest to keep it at a minimum, be really skilled and really thoughtful about the data that you're collecting, that you're proposing to add into the process, because that will add a cost and effort within that. You need to ensure that you understand data quality. Do you know what this means? Do you understand where the data's come from? Do you understand, is it a zero? or is it missing data? Those kind of aspects. You really understand the context behind the data. So if you're looking at, say, again, hospital admissions and hospital, number of patients in beds in a hospital, it'd be quite different at 12 o'clock at noon than 12 o'clock at midnight. So if you're looking at data that talks about occupied beds, what time of day is that? Is it 8 o'clock in the morning, 8 o'clock in the evening, 12 o'clock? Because those things will look quite different. And again, you need to make sure if you're comparing against organizations or different data sets that that you are comparing the same thing. And we've found that you often need expertise to understand the data. And that expertise is split between analytics experts that understand how the data has been transformed, how it's been manipulated and summarized, as well as our clinical colleagues that know actually what the data is actually saying. And it's actually where the clinical and analytical expertise comes together that you really can get that understanding. And often that's something that needs to be worked through for a number of reasons. One is you'll get better understanding of the data, but also it will help you understand from both the analysts and the clinician's perspective what's important to them to measure. So really important to understand what that data is that you're getting. As I mentioned before, how do you include patient and user experience, and how do you include staff experience? Because that's really important as well. Can we introduce things that will give staff? It might be safer for the patient, but also does it give? Will it have an impact on staff? Will they have a better job satisfaction? Will it reduce their anxiety? Will it reduce their concerns around this? Around this particular activity. So again, including staff experience, and that can be key if you're expecting the staff to change. So we can articulate what difference it will make for them based on the difference it's made for their colleagues. So do you understand the data quality issues? Are there any data quality issues related to the data? Is it missing data? What does that mean? How is missing data represented? Those kind of aspects. Do we understand the definition? Is everyone consistent? Is everyone consistent with that in the way that they've interpreted those? Are we confident that the definition has been applied consistently? And do we understand how it's been collected? Has it been collected in a way that ensures that that we're comfortable that it's been collected accurately? I think we also need to acknowledge the limitations and what can be interpreted from the data. And one of the things that's happening generally in analytics is there's a lot more work going into those definitions and how collected, and also what can be understood and what cannot be understood and interpreted from a piece of analysis and piece of data. I think it's really important to consider those things. So examples of data that is out there that is potentially useful, but is publicly available. NHS England have a huge amount of data on lots of different aspects of care, and just some of them, and perhaps the ones that are most common maybe, are the quality and outcome frameworks for in primary care. Has disease registers, treatment registers. Really can be, if it's in quality and outcome framework, you can get data at practice level. We have prescribing data that's publicly available, but that is on the items dispensed, not necessarily for the number of patients, but there is data around prescribing out there. We've got ambulance data, there's A&E data, emergency care data metrics, hospital episode statistics. Some of that is available. Certainly, I think it's more on national level, but some of that's available, and some of that more detailed isn't available for HES, and a whole range of data that's available. There's also those clinical audit data, and some of those are national clinical audits, such as HQIP. They may have some data that's relevant, or it may be that we're working with a particular project. If they've submitted data for a national audit, they might have local versions that through the appropriate governance, they can analyse and perhaps share some of the findings from there that's relevant. That might be something to explore. We've got public health data. Fingertips is used extensively. It's wonderful. Lots of information on there, as well as quality indicators that people are using both the internal and the external quality indicators. And some of those are featuring model health system, girth, shape, etc. Those, for the nature of the data, the access to that is restricted to some of those because of the nature of the data on some of those systems. So that's usually restricted to health and care colleagues, and maybe only and some aspects to data that relates to their particular organisations. But that data is out there and always worth exploring. A very brief introduction into measuring benefits, identifying and measuring benefits. When I did the Cranfield course back in the day, I think it was 3 days just on identifying benefits back in the day. So to do that in 20 minutes is, I don't know, somewhat unrealistic, but hopefully it's given people a flavour and some ideas of and the importance of identifying benefits, and then leading on to how some of those can be measured. It's not easy. If it was very, very easy, we probably wouldn't need this session. It is challenging. And we've understood in sort of not in a very deep way, but we've understood some of the challenges in undertaking that work. In this work, and recognise that it is challenging, but I think it's incredibly important, and it's very rewarding to do that, because if you can feed back to people and say, you delivered this change, we know it was difficult, this is the impact, that can be really, really quite powerful. So additional resources. So we've got the benefits management stuff on NHS Digital. We've got NHS Impact, both really useful resources to look at. Unfortunately, it's limited to health and care system college only because of some of the data withheld within them, and we could spend lots of time talking about data and data management. But there's a model hospital, model health system, and also the future NHS Innovation Collaborative. There's a section on benefits and impact, loads of really, really useful slides, some of which you will see that I've stolen with pride, some of those, and lots more resources on there. Making data count, there's the publication in the public domain, but also future NHS. And again, I would suggest that's a really good way of people looking and understanding the role of statistical process control, and measuring things over time. Lots of training on there, lots of really, really good stuff on there, and actually the team have revolutionised board reporting, for example, and supporting making those decisions. Health Foundation, about evaluation, and also the Health Innovation Network's guide to real world evaluation, and some more work will be coming out, I understand, from the network on that. And again, the shape tool, amazing tool. There's so much that is on there. Really, really useful tool. If there are any future events and topics, let us know. Let us know what will be useful. And I'll just a shout out to the Innovation Academy, hosted by the East Midlands. But that's a free resource designed for innovators, but there's topics that may be useful for health and care colleagues as well. And if it doesn't put you off, I deliver a different session on there as well that people can access. So there's some resources out there. But if there are things that you found that will find useful, let us know. Let us know in the network, because we're really keen to provide that support. And I'd just like to round off by thanking Julie and Shanice for doing all the hard work of operating all the polls and everything else. Annie for help on the slides, and as well as Julie and Shanice, of course. And all the work that goes in. We are a team when we deliver that. So I'd just like to say thank you. I'm pleased that I finished on time. Thank you very much indeed for your time. Hope you found that useful, and enjoy the rest of the day, and hope it's still sunny everywhere. Thank you very much indeed.